Hello, everybody. Welcome, and thank you so much for joining us this evening. We are so glad that you're here. My name is Jessica Frappampina, and I'm a National Account Representative for Myriad Neuroscience based out of the Raleigh, North Carolina area, and have been here for 6 years and truly love what I do. I'm so grateful to be here, and I'm grateful that you've joined us. I'm going to be moderating today's discussion, and today's discussion is going to be centered around a thought-provoking topic in the geriatric space in which we will ask ourselves, could what we presume to be typical senior moments actually be depression? As we engage in this important conversation, I want us to really all come from a place of truth and compassion, remembering and realizing that we will all hopefully continue to age, and we will most likely quite possibly be in this vulnerable population's shoes one day. That all being said, you guys are the experts in this space. I know you spend a lot of your time treating geriatric depression and working with the geriatric population, or I'm assuming you do, or you wouldn't probably be on the call this evening. So that being said, we really love hearing from you guys as the experts in the space and want this to be as interactive and conversational as possible. So please, if you could utilize our chat feature to ask any questions, express any thoughts, or maybe it's just an aha moment where you're like, I didn't realize I was doing that, or you know what, yeah, you're right, or maybe it's something that you disagree with. We definitely want to hear from you, so please use the Zoom chat feature to do so. To jumpstart the conversation, I want to go ahead and introduce to you all our expert panelists that we have with us this evening. So we have Dr. Ben Inventor, who is the Director of Adult-Gerontology Primary Care Nurse Practitioner Program and Assistant Professor at the Department of Adult Health and Gerontological Nursing at Rush University from Chicago, Illinois. Thank you so much for being with us tonight, Dr. Inventor.
Glad to be here.
Thank you. We also have Dr. Deshmukh, who is a triple board certified psychiatrist based out of the Central Florida area. He is also the CEO and medical director of Balanced Wellbeing, which is a long-term care provider group in which him and his staff visit many nursing homes throughout the state of Florida. So thanks for being with us tonight, Dr. Deshmukh.
Thank you.
Thanks. And then we also have Faye Bembry, who is a psychiatric mental health nurse practitioner with Team Health, and she's based out of Johnson City, Tennessee. And for those of you who don't know, Team Health is also a long-term care provider group that has a wonderful behavioral health care program servicing the Southeast. So thanks for being with us, Faye.
Thank you for having me.
Absolutely. And then we also have Lesa Caffee, who is a nurse practitioner with Senior Wellness Group based out of Royal Oak, Michigan. Thanks for being here, Lesa.
Thank you. It's good to be here.
Awesome. And then we also have, last but not least, Charlene Jervis, who is our Social Services Director at Majestic Care in Fort Wayne, Indiana. Thanks for being here, Charlene.
Thank you for inviting me.
Absolutely. And so thank you all of the panelists for being here. And then thank you as well to the audience for joining us this evening. I know you all are super busy, but we've got a really important topic to discuss. So I just want to remind you the learning objectives for tonight's session, and then again for Thursday, we hope to see you back. But tonight we're going to be talking about how to recognize pandemic-related depression in senior patients, and particularly for those living in the long-term care setting, so like your skilled nursing facilities and assisted living facilities. And then we're also going to be talking about treatment options, including telehealth, as 2020 has changed a lot for us, and telehealth is really probably part of our daily activities for most of us on this call now. And then on Thursday, we are going to be talking about self-care tactics for providers, including monitoring one's own mental health and asking for help. And I think this is really important and going to be a really great engaging conversation, because I think a lot of times in this space, people forget that healthcare providers and nurses and the individuals working with your loved ones at these nursing homes are also human. And the pandemic and depression and anxiety, all of that is very real to them and to us as well. And so we need to be able to ask for help and realize when we need to do so. And then on Thursday, we're also going to be talking about the importance of setting depression treatment goals of remission and resolution for patients versus sometimes, unfortunately, kind of feeling like that struggle between getting them to remission, or just really struggling to get them stabilized at the age that they're at with all the different comorbidities and everything going on. And then again, I'll say it again, but it goes without being said, this is all going to be looked at through the lens of COVID-19, as it has drastically affected all of our worlds, but especially in the geriatric healthcare population. So I guess we can go ahead and get it started. To kick things off tonight, I just wanted to ask each one of our panelists to start off with a 1-minute statement with your personal feelings about the problem with depression treatment in older adults as you see and experience it. And we can go ahead and start with Dr. Ben Inventor on this one.
Again, thank you so much for inviting me to come here and speak to everybody. I'm really excited to share what my experiences are because of two things. One is because it's psychiatry, and I love psychiatry. I love to help with the mental health of our patients. And then two, because it's specific for geriatrics. And I am very, very interested, and that's my specialty also, is in geriatrics. And so to merge them all both together, that's very exciting for me. It's very challenging to diagnose depression in older folks to begin with, and then you add on top of that the COVID pandemic, then it magnifies the challenges that all of us clinicians and providers and everybody who work with older adults in terms of caring for them for their depression or any other mood or behavior symptoms, very challenging. One is because it's on top of another, there's a challenge, extraneous challenges, and two, innate to older adults, you have challenges itself when it comes to managing and recognizing depression. Very atypical presentations, you don't see that quite often with younger folks, and the aging changes in the body presents a challenge to manage the depression in older adults. So I really look forward to hearing everybody's thoughts about this. I don't want to take up everybody's time, so I stop at 1 minute.
Thanks, Dr. Inventor. And everyone can kind of just follow in as well with their responses. I'm not going to point to you individually, so whoever wants to give their 1-minute statement next about just, the problem with depression treatment specifically in older adults right now.
I'll go next. So the problem I see has to do with sort of this common perception that the elderly population don't experience the same issues that younger people do. And I feel like that belief leads to a lack of reporting and appreciation of issues with depression in that population. Caregivers and also providers often address physical symptoms without realizing that mental issues may be at the root of the problem. For instance, some of our patients report memory loss or self-care deficits, which can actually be symptoms of depression and may be mistaken for some of their physical issues. Now, certainly this population has a multitude of medical problems. So sometimes we get so focused on their medical issues that we forget to address some of the mental health issues. And as we know, when depression is treated, a rehospitalization rate and hospital length of stay goes down. So it really behooves us to look for these symptoms and treat them appropriately.
I can go next. What I've found out is that a lot of the patients in long-term care facilities with their slowed cognitive processing, executive function decline, that the patients with dementia that have the cognitive impairment, the lack of ability to speak, or the decline word salad, that they struggle a lot more trying to isolate and define depression in them. And then usually the ones that are the quiet, mousier ones that stay in the room, that are more isolative, are the ones you don't hear about or aren't assessed as much for depression. It's usually the ones that are having all of the behaviors and the issues that people are coming to me to say, hey, we need med changes on them, but they never address the ones that are quiet and isolating into their rooms.
And I'll go from there. I would agree with that. The quieter, mousier ones are the ones that, as social services, when we do our PHQ-9s, I know for a fact, many of us in the Majestic Care world, we start our PHQ-9s, we start them on paper day one of the ARD, and we evaluate them for depression each day for the 7 days of the ARD. And if we see any changes at all, you know, the UTIs can set off depression and different things like that. So we definitely watch for our ones that have come out but now aren't coming out, or are ones who are always quiet, shy, and reserved. We want to make sure we're not missing their depression symptoms, especially during COVID.
I agree with all that. Depression, that the way it presents in geriatrics can be typical or it can be atypical because of their aging brain and also because of the circumstances. And the other thing is the cognitive impairment that makes it more likely to be atypical. Now, it is very common. 40 to 50% of the patients in nursing homes have depression, as per the research says. But the good news is that it is treatable and we have effective treatments available. What makes me excited about geriatrics is that we can make a real difference in their lives, because once they're in nursing home, the medication compliance is more monitored and patients can show dramatic improvement if they are given the right treatment. The other good thing about working in nursing homes is that we can monitor their behaviors 24/7, and we can pick up on the objective symptoms of depression. So even if they're not telling that they're depressed, we can pick it up and we can make a difference in their lives by treating it. Now, as one of the panelists has said, that treating depression have many benefits, such as not only improving their symptoms and their quality of life, but also improving their recovery and improvement in their medical health condition. So that makes me excited about geriatric psychiatry, that we can pick up the pathologies very early on and we can make a difference early on. However, it is known that geriatric depression can be easily missed, and particularly the reason it gets missed is because those who are more showing outward behavior such as agitation, aggression, combativeness can get attention, whereas those who are withdrawn, staying quiet, can get less attention, and so we can miss it. However, if we providers, if we're well trained and we're well mindful of these facts of geriatric depression, I think we can make not only a difference in the lives of the patients, but also their family members, and also we can impact their healthcare cost.
Absolutely. Yeah. Thank you, Dr. Deshmukh, and to all the panelists. You know, I think that you brought up a lot of really great points, and two of the commonalities that I've kind of picked out from what you all have said is, one of them is, you know, it's something that we often like to say over here at GeneSight is like, if the rest of the body, or if the brain isn't right, the rest of the body isn't going to be right either. And so kind of to what Faye was saying, that makes perfect sense, you know, and it's unfortunate if geriatric depression is going to be overlooked and missed, because it truly does affect the entire rest of their health, their healthcare, and it affects the loved ones as well that care for them and care about them. And then the second thing is COVID, right? That's obviously made things really, really challenging, especially amongst this population and treating depression. And so I want to dive into that a little bit deeper and kind of talk about, you know, we understand that about half of US adults age 65 and older reported that their mental health has been negatively impacted due to worry and anxiety and stress over the virus. And so I'm curious to hear from you guys, like, are you seeing this in your practice, in your day-to-day life? And how have you changed your diagnostic and your treatment procedures in light of the pandemic? If we could start with you, Dr. Deshmukh.
Sure, thank you. So I would like to step back a little bit and start with painting the picture before COVID and then how it got affected after COVID. So first of all, coming to nursing homes or any long-term care facility has not been easy. It has always been challenging, because when a resident comes from their outside community life and they get placed into nursing home, they have already gone through a lot of transition. And just to name few, they used to work and they used to be employed, and now they don't anymore. And they have lost their identity, whether it's electrician, whether it is a researcher, whether it is a doctor, or whatever they used to pursue. They had a pride in that, and not anymore. That's the challenge of declining age, that they cannot pursue their profession. The other thing is they are losing their vigor and vitality as the age is progressing. They're not able to do things as they used to do. They are not able to pursue their hobbies as they used to do, their interest. And their health is declining day by day. So they are getting more and more physically dependent, more and more uncertainties about their health, what is going to happen, the pain, physical pain, the impact of it, the ongoing other health issues, the placement into hospital, uncertainties about that. And then on top of that, they're losing their independence, and they're becoming dependent. They're losing their dignity because now they have to be dependent on others, where in life they have been independent all along, supporting others. Now they have to be supported themselves. And they're losing their friends, and they're losing their spouses just because they're aging and they're dying. So there's a lot of transition going on, and the families are not visiting as often as they would like to some of the residents. That's an issue. So it has always been a difficult. And to not get depressed, I would say, is unnatural when they come to nursing home. Getting depressed is natural phenomena. However, the severity of it really matters. So as I said, 40 to 50% of the residents in nursing home have clinical depression. And we have to identify that. That was before COVID. And now with COVID, as you can imagine, their uncertainties about their health and about their loved ones have gone up. Fear of dying has gone up. And restricted visitations from family. So in typical condition, the doctors would go to nursing home, the staff would go, the counselors would go, we will provide the support, the families would visit. And that kind of offset a lot of depression that is developing. But during COVID time, the restricted visitations from family, restricted visitations from doctors is another factor. And even those who are visiting the facilities, they're wearing PPE and they're putting the mask and face shields. So really human-to-human contact has been really limited. And then the TV is on because there are no activities. They're not allowed to go in groups and do the activities like bingo or eating together. It's not allowed. So they're isolated. They're sitting in the room watching the TV. And what is on the TV? It's all negative news about COVID. So you can imagine the impact of COVID on their mental health. So the depression has definitely gone up. I don't think there are studies right now available how much it has gone up because of COVID, but I'm pretty sure they will be available in near future. But it is significantly gone up, and we have to be mindful of this fact. Now, personally in my practice, although I have seen the depression is going up, my protocols have not changed because we have always been proactive in identifying the signs and symptoms of depression, whether it is typical or atypical, and taking the proactive measures. But our treatments have definitely gone up because we are identifying more depression, we are treating more depression. Typically, we would start with an antidepressant medication with as much emotional support we can give with restricted visitation. But we know that research shows that only 50% of the time the medications work in the first trial. And so we have to keep on trying what other medications would be better, trying various combination dosages. And that's where we have been utilizing the GeneSight testing, where things get more complicated and they are not responding easily to our primary treatment, and we need more guidance. That's when we are utilizing GeneSight. So the bottom line is depression has always been common in nursing homes. It has become more common during COVID time. Depression has a characteristics in such a way that it can get missed. And during COVID, it can be further missed because the staff is limited, the resources are limited. And so that's how the impact of COVID has been. But in terms of treatments, the treatments are restricted again because counseling and visitations are limited, but medication treatments are still available, and we can make difference. And sometimes we have to take use of
Absolutely. Yeah, absolutely. You bring up a lot of really great points, and I'm actually curious to hear as well from Faye, since you go to a lot of different nursing homes on this topic as well. What are you seeing? Do you agree?
Certainly. I think, number one, the limitations on families. We've seen declines in our dementia patients. They seem to be deteriorating faster. We do see a lot of depression. What I'm doing in my practice is we are trying to encourage social activities that we can. For instance, some of our facilities have been able to do bingo in the hallway with each patient sitting at their doorway with a mask on. So we're trying to utilize as much interaction as we can. We're trying to allow the patients to FaceTime with their families. And in a lot of our facilities, activities, that's what it's become. It's become the activities staff now being in charge of helping patients connect with their family through FaceTime. So that's been a good thing. But I certainly agree that we're seeing a lot more depression, and we still need to treat it. And we still need to, be aggressive with the treatment so that our patients don't deteriorate. So I certainly agree with that.
Yeah, absolutely. I think now more than ever, we have to be really aware and, hey, is this depression that was pre-existing? Is it from COVID? And just like what you said, what you guys are doing to be creative and getting families involved, to avoid that isolation that both Dr. Deshmukh and you mentioned. And I'm also curious to hear from Dr. Inventor. You could kind of weigh in your thoughts on what you're seeing and if you guys are maybe doing some of the same things.
Well, the difference between now is because now we used to diagnose people by ourselves, right? We come in, we interview patients, we interview families, we interview staff, but now it becomes a partnership with the people in the nursing home. We are not allowed to, let's say, go in and talk to the patients. So now we are in partnership with staff in looking at diagnosing, assessing what are the symptoms that these patients exhibit. And so we are also, I would say that depending on how much ability and how much information can staff share with us, the better the better it is. The staff are the ones with the patients 24 hours a day. And so we rely on them. Even when pre-COVID, we come into a nursing facility and then we only see patients within 20 or 30 minutes, and we make the diagnosis the best diagnosis that we can, make the diagnosis that we can. But then now it's even magnified, that we are limited sometimes with the information that we have, and we cannot see these kind of silent features, but then we relied on the partnerships that we have. I mean, pre-COVID, depression is very difficult already. It's undertreated, under-recognized for most of older adults because of many issues of diagnosing it. Mm-hmm. Ageism is one of them. They think that it's part of normal aging, but then you bring COVID, then it becomes even more magnified.
100%. Yeah, I mean, you bring up such great points, and I actually am really curious to hear from Charlynne because, like you said, partnering with the staff because they are there 24/7, they really understand what's going on and can really alert you to some first signs. And, maybe this is depression, or maybe this is something more serious than what we originally thought. And this is something, just in working with Dr. Deshmukh in Florida, something I see him doing all the time. So Charlynne, I'm curious to hear from you on this question as well.
Well, what we've noticed, especially with COVID, is we are a behavioral psychiatric facility. And a lot of our residents, their families live 3, 4, 5 hours away. Our residents come to us from all over the state of Indiana. So we have had to learn to use Zoom, Duo, FaceTime, and it's hard to get your 90-year-old residents to understand that their daughter is in your phone, but she can't touch her. It's also difficult because you think about it, the greatest generation, they're not, back in that day, they don't talk about depression. That is a taboo. It is not something to be talked about. And so they won't tell you, I'm depressed. I miss my daughter. I miss my husband. I miss my family. We have one resident, she's been married for 70 years. She has not seen her husband since January. But we did finally get him to learn to do Duo and Zoom and all that. But we've had to really, GeneSight was a great tool for us with her because we were able to look at her depression medication. My Psych NP is wonderful, and she was able, we looked at different concoctions, you know, a little Paxil, a little Lexapro, what works the best for her. And she also has sundowners in the afternoon. So you throw that into the mix. One thing COVID has definitely brought about, we have a lot more sundowners coming out because they are so isolated. And that just, it's heartbreaking. Being in the facility, it's heartbreaking. And you do rely on your staff. You rely on your staff to call you if someone's psychiatric condition changes, their mental health changes. My staff is very good about that. They will call me and they'll say, hey, Char, you know, somebody, they're not acting themselves today. Something's wrong. So we'll run the usual medical things, but when the labs come back normal, the UACNS comes back normal, then you really dig a little deeper and you start looking into, you know, when was the last time they saw their family? When was the last time they talked to their daughter? What's their food intakes? And that's another thing. We've seen a lot of weight loss with COVID because they're so depressed they don't want to eat.
Yeah, you know, those are so many great points, and I could take each one of those in so many different directions. You know, but you brought up something really interesting in particular about the residents and just like the taboo of depression for that age group. That's so true. And I think that's something that we also possibly overlook as to possibly the reluctancy there and wanting to talk about depression. And then also the foreign, you know, part of the phone, being able to talk to their loved ones through the phone. That's got to feel so foreign and just weird to them. And then having the staff's ability, which by the way, we appreciate you guys so much. I know what you're doing right now is not easy. Having y'all's ability to then take that, you know, iPad or that phone around to connect them with loved ones and do their telehealth visit is not easy. So, you know, we really appreciate what you guys are doing out there. And I wanted to kind of loop Lesa into this conversation as well. It's a really great segue into the next question is, you know, how is COVID-19 actually affecting the residents in long-term care facilities? And as a healthcare provider, like how are you recognizing the pandemic-related depression in the facility?
I think overall, with the restriction of the visiting, isolating them more to their rooms, they're now getting lunch trays in their rooms versus going in the dining room for socializing. All of those are contributing to the impact of the depression. You're seeing a lot more failure to thrive, the weight loss, like Charlene said. I just think overall, the COVID pandemic is going to have a lot more long-term effects on the residents than we even anticipate or can see at this point. I think a lot of the individuals are already struggling with the emotional symptoms of being in the long-term care facilities. Now you've taken away all the components of being able to see their friends, their family. Window visits help some. Oftentimes, because you can't hear through the windows, you've got one person here with the phone and then they're on the phone out there, but you can still at least see them and communicate. That helps a little bit. The biggest things to do is you be proactive with your patients. You make sure you talk to them, even ask them, how are you feeling today? How's COVID affecting you? How's the depression, anxiety? How's your overall mood, sleeping? How's your appetite been? Routinely screen them, teach your staff, whether it's activities, social worker, the aides just in general to assess how their patient or resident is doing. Offer emotional support to them. You're the ones on the COVID units. Granted, there's no touching, but do the best you can. The ones that are asymptomatic, go ahead and touch their hand. Give them some type of emotional connection that they're not getting with COVID. pay particular attention to the ones that do have a history of mental health issues, because those are the ones that are going to spiral out of control first. Make sure you have education for the staff so that they know what to look for, what are the signs and symptoms. Granted, they didn't eat lunch today or dinner, but maybe they didn't feel well, or the fact that, okay, this is becoming a pattern. How many days haven't they eaten lunch and dinner, but they're only eating breakfast? What's going on with that? And really start focusing and making sure that during this time that with all the social distancing, that we're not emotionally distancing from the residents at all to keep them healthy and well.
Yeah, I would like to continue on it further that yes, in our facilities, we have been doing a lot of efforts to bring their life back to normalcy as much as possible. However, there are significant limitations. So for example, doing the family visit via iPad, our patients are not technologically savvy. They don't understand technology in their geriatric ages. They're hard of hearing, and it's just not doing enough justice as compared to the direct family visit. Similarly, yes, we have been trying to do bingo games and we have been trying to do the window visits and as much socialization as possible. It's not going to be similar as what they used to have. And so we have to be realistic here that our patients are geriatric. Many of them cannot even participate in psychotherapy. Those who are able to participate, the iPad psychotherapy or telephone psychotherapy is not the same. So realistically, I am expecting and I'm seeing the medication usage is going to go on a higher side. And it is okay because medicines are effective and we may have to use them for time being, even when they never had a medicine. And it's completely fine. And then when the things will slow down and when things will start getting better, maybe we can cut back on those medicines. But I am expecting and I'm seeing the increase in the usage of medicine. And I do want everyone to know that we would not be afraid of it, that medicines are effective and if they're properly used, they can still make a difference. We don't have to make our residents suffer because we have reservations against medicines. We can educate ourselves and get more comfortable and not be afraid of taking the right actions for our residents.
I also wanted to piggyback actually, Dr. Deshmukh, about the medications. You know, in long-term care facilities, we are kind of programmed to do GDRs, every gradual dose reductions in medications. And this is not the time actually to do GDRs. I think it is that the residents have the highest risk for relapse with isolation and stress and everything that's going on with them. The support system is down. So I think it's your, you know, I've been justifying the use of medications and stuff like that. Now, the question is, are the medications the right medications for the patients? Because some of these patients are on medications for a very long time, but then when you don't see the therapeutic response to medications, then that's the time that you need to modify treatment. That's the time that you adjust and add medications and tinker with the dosing and stuff like that, especially with older adults. And so that's the reason why it's very important to medicate, but it's very important to medicate correctly and appropriately. So you know, that's why it's very very good to have the tools that we can, including our genetic testing to medicate people.
Yeah, I'm just seeing a question that just came up, which does say that GDRs are counterproductive during COVID time. It is largely true because this amount of stress. However, the pressures for GDRs on providers have not decreased during COVID time, and I think we need to do more advocacy there at the governmental level that the GDRs are still something that we have to do. We need to be just more mindful and do appropriate GDRs whenever possible. For some residents, some medications may already been working great, but now with the added stress, the medications are not enough, those doses or those medication itself. And I agree with Dr. Inventor that this could be a time where we have to do more medication changes, and having a tool like GeneSight can help us significantly. Sorry, Faye, go ahead.
No, that's okay. The point I was going to bring up too is that we often see patients started on medication, but the dose is never titrated up to get a therapeutic response. So certainly with our geriatric population, we want to start low and go slow, but we also want to give them a dose of a medication that's going to be therapeutic to treat their symptoms. So I find in these times that I rely on some of our objective data, like our PHQ-9, our geriatric depression scale, our Cornell scale for depression and dementia, and do that testing before treatment and then after treatment to make sure that we're getting that response. The one thing about telehealth is I can give these tools to the staff to do, and I can request, okay, let's do a geriatric depression scale if we're concerned, or let's do a Cornell or a PHQ-9, and then let's follow it up after treatment and make sure our numbers are improving. So during that time, I think it's important, you know, especially if you're using telehealth, some of these objective tools can be very helpful.
I agree. I just want to add one more line to that, using the geriatric tools, I have always promoted that and advocated for that, and it's called as measurement-based care, and there are tons of research available how beneficial it is. During COVID time, I am facing problems at the facility level with their staffing, because as they're finding, they're doing the weekly or bi-weekly testing, they're finding staff that is coming positive for COVID, and therefore they have to quarantine, or sometimes staff is sick, may not be COVID, but they think that they have COVID. And so they're extremely limited on the staffing. And on top of that, they have so many additional checks now that they have to do, and additional responsibilities they have to do, that I am personally finding it is difficult to find a staff member who can go above and beyond as they used to do in past. That being said, I agree with you that yes, measurement-based care is wonderful, but personally in my practice, we have seen that difficulty. And so we are going by our best clinical judgment based on our clinical objective, subjective interview. And another thing that GeneSight helps with dosing adjustment, it also tells how they're going to metabolize the medicine and what dose adjustment is expected for their genetic profile. So that is useful in dosing adjustment.
Yeah, those are all really great points. And I know GDRs, that's a huge hot button. And so it was really interesting to see the dynamic and conversation and discussion here. I'm actually curious, I want to just loop in Charlynne really quickly on this, being that you work at the facility and understanding that there's such strong regulations with GDRs as well for the facility. I'm curious to hear your perspective and opinion on that.
Well, I would agree that right now GDRs are very counterproductive. It does no good to GDR any antidepressant right now. The residents have not seen their families. We locked down March 3rd. We did have a few weeks of outside visits, and then we had to cancel them. So GDRs are very counterproductive. There's no reason for a GDR right now, but you can't tell the State Board of Health that. They don't like to hear that answer. And I'm not disrespecting anyone who may be on with the State Board of Health.
Oh, Charlynne, you muted yourself. There we go. There you go.
Apparently, yes, someone wanted to call me. So I do have my GDRs. I have a very good rapport with my staff and with my psych nurse practitioner. I also have an LCSW that comes in, and she doesn't work in the facility. She works for an outside company. So she's able to see things from an outside of box perspective. She may be able to pick up on some depression that I am not picking up on, or they may tell her something they don't want to tell me, which is rare, but it happens. And, you know, we always discuss during GDRs, we have this great thing in PCC in the taskbar. You can add in everything on the PHQ-9. We do it 7 days before the ARD starts. And then we leave it for the 7 days of the ARD. So you're able to capture a 14-day overview 24/7 of any increase in depressive symptoms, which we also take to our GDR meetings. And then we all sit down as a collective group, a good clinical group, and we'll be like, no, this is not the time to GDR anything. And then we will write a clinically contraindicated note. But as we say, if you didn't document it, it didn't happen.
Yeah, it's very important to document. And I actually just, you know, on that point, you know, 2020, a lot has changed, right? Due to COVID. COVID has changed a lot for us all. So do any of you all think that the GDR regulations are going to lessen or change because of COVID, because of all the increase in depression and suicide and this, you know, especially in this vulnerable geriatric population? What do you see happening?
I wanted to just talk about GDRs. I mean, it's a best practice for older adults that medications can be reduced. As you know, somebody who works with older adults, the best practice is to use the lowest dose possible for all these medications to control symptoms, right? And so I think it's a best practice. However, if you try to reduce medications, if you try a reduction and then the patient relapse, you have justification that you did try it and the patient relapse. It's like a balancing act between the benefits of medications at the current dose and not benefits of medications at the current dose. I mean, you could not blame the powers that need be, because some folks are actually over medicated. I mean, I've seen people use medications inappropriately. It's all documented in the literature to deprescribe medications because of polypharmacy and all those things. But then there's always something right for someone. And so if GDR is contraindicated for that person, if it's documented, it's fine. I mean, I have gone through so many surveys in my life, both as a nurse before, as a DON before, and now as a clinician, and the document saves you. I mean, it saves, that's your rationale for using what medications you use. There's a question in the box there about what you feel about antipsychotic medications. I would say that if it's really necessary, why would you deny someone if it's necessary? I think the question is it the right medication to use? Antipsychotics, yes, there's a black box warning for older adults. Increased risk for death, cardiovascular, pneumonia, and all those negative consequences. But there's also a time that you can use it correctly. If the quality of life of someone is so down because of psychosis, I mean, that's not the way to live either. So I think there's a right way to use antipsychotic. There's an appropriate way to use medications. Even Tylenol can be used inappropriately. That's what I tell patients.
Very true.
So
Yeah.
Yeah, I would like to give my personal spin on it that GDRs, why it might have the regulations, why it might have came into existence. At one time, definitely there was inappropriate usage of the medications. Patients were neglected and they were getting put on the wrong medication at wrong dosages. And I have seen that in my career as well, even after the GDR rule came in, that patients are on inappropriate medicines many a times. So I agree with Dr. Inventor that GDR rule has a purpose and it is serving the residents, and it has, if we utilize it properly, it is going to help our residents. Now, if we want to talk about antipsychotic is a big red flag in the nursing home. It has gotten a very bad reputation because of that black box warning studies that came in. But I know that the Geriatric Psychiatric Association have been fighting against it because it has blown out of proportion. The antipsychotic medications have been very effective. We know that we have been using it in general adults and younger adults in outpatient setting and hospitals, and it works for a variety of conditions, and it can work in geriatrics as well. Again, all medicines have side effects and we have to be very careful. And so the antipsychotic medicine have a role, and if we can utilize them appropriately, as Dr. Inventor said, that it can bring good. And if we can be mindful of GDR and do it appropriately, then it will definitely help the residents. However, we have to be careful not to do too much GDRs and to make sure it individualized care, individual-based presentation and treatment plan can help them.
Yeah, you bring up another great point, Dr. Deshmukh. It's kind of, you're in a rock and a hard place because, the intention of a GDR is good, right? We want to make sure they're not over-medicated, but sometimes it's just, it's a lot easier said than done, and each individual is different, right? Which brings up the topic of personalized medicine. And I'm curious to hear from Faye, and then maybe also Lesa as well, what your perspective is on this topic.
Yeah, I mean, I agree with others that certainly the GDR movement has a good intention. And for duplicate therapies, like when we have a patient that's been treated with one antidepressant and someone's added another, never taking away the first one that didn't work, for instance, or maybe we inherit these people from somewhere else and we don't know. So it's really important, I think, to, like you said, to individualize treatment for these patients. I do agree with others that GeneSight is a great way to do this. And I think we just have to take the time to ask the questions, what medicine has helped you the most, or which ones have not worked? And then we can sort of avoid other failures. But we can certainly document on our GDRs. I mean, the requirement is really that you respond to the GDR, right? That you address it. Not so much that you say yes to every dose reduction, but that you document that the patient is benefiting from therapy, that they're under increased stressors currently with, and you can put that, there's increased stressors with medical issues or family stressors. Therefore, we're not going to attempt a GDR at this time. And I think that's perfectly acceptable.
I often see it in some of my facilities where they come in and they're admitted on, especially on a locked behavior unit, where they have 4 or 5 different antipsychotics that they're already on, and they're telling me they're having behaviors, we need more. And you're like, well, let me reduce these and then we can go from there. And they're like, no, they're already having behaviors. I'm like, but you don't understand that if they're having the behaviors, obviously these meds are not the right ones. Otherwise their behaviors would be under control, their overall mood would be stable. And since none of that is occurring, then we have to cut back on the ones that are already on board. Once you have the GeneSight testing, you can indicate which works better and which doesn't, and then you can show them the handout and say, okay, these aren't working for these reasons. Let's go ahead and I can remove these 3, but then I can add this one. And then other times the facilities will push you for one of the 4 criteria to be on an antipsychotic. Either the schizoaffective, the schizophrenia, Tourette's, or Huntington's. So they're like, oh, they need a diagnosis because they're on this antipsychotic. And then the facilities get upset with you when you won't give them a diagnosis just because they're on the antipsychotic. And you're like, I'm giving it to them because they are treatment-resistant depression. I'm not giving it to them because they have psychosis. And then the facilities get upset, well, we can't have that medication. But if you have it documented, then yes, you can have that medication. That I've tried A, B, and C, D. I've tried all these drug classes. None of them are working. This is what's helping this patient with their depression. And then when state comes in and does the survey, they will look at the chart. They will say, okay, these options have been tried. They failed. So she's on it for the treatment-resistant depression. And then therefore, they will be okay.
Yeah. No, you bring up some really valid points. And actually one of your big points was the behaviors. They're clearly a big issue in the facilities, and we want to try to avoid those. But to your point again, it could be for a multitude of different reasons. There's a lot of different moving parts in mental health, and it's not so easily done. So on that point, I want to ask, how does getting a patient's depression under control help get others under control? Because this is a domino effect. It does not just affect them, it affects their loved ones, their caregivers, the facility, the whole 9 yards. And I want to open that up to anyone.
Yeah, I was going to say that I've seen in rooms where patients have roommates, when you treat one patient and get their depression improved, it typically helps the roommate. If you can imagine somebody withdrawing and isolating where they used to have a conversation with their roommate or be a companion to them, and now they're not. certainly I've seen that be helpful. But I agree that the milieu of what's going on in particular units has an effect, and the better we can make one patient, it may help another. So I agree with that.
I also wanted to add about personalizing medicine, especially when people with dementia. I think many folks, well, not many folks, or I've seen some staff or something that would rely on medications as the very first line, which is not supposed to be. For folks with dementia or on behaviors or any behavioral or psychological symptoms, they need to try first the non-pharmacological interventions, and if that fails, then go to the next step, which are medicine. So I think that's also another issue that we need to drive at, that we need to, for folks with dementia, that you need to do that. You need to try that. You know, the regulators are if they see these documents that you're using all these things and justify your actions every step of the way, I don't think they will argue with you. So the documentations are there, and if the challenges for us is to document and to use everything that is in our treatment options the best that we can, and so you know, just use it. That's just my spiel on. I just wanted to add that especially in depression with dementia, because sometimes those can be difficult to kind of tease out, and so I just want to add that in.
One thing I want to go step back a little bit and go back to the GDR point is that sometimes we can be creative in doing GDRs, and what I have been successful at is utilizing more effective dosages rather than multiple medication with small dosages. So for example, a patient may be on 50 milligram Zoloft and 5 milligram Buspar 3 times a day. And having GeneSight can really help in that case also, because it can say Zoloft is better metabolized than Buspar. So we can just go up on Zoloft and get rid of Buspar. So we are not only helping the resident, but also showing the GDRs, because one medicine is less. So we can be creative there and achieve that through our clinical experience as well as through the help of GeneSight. Going to the next question about how depression can benefit other aspects of life. I have always been a believer that a body cannot recover and heal faster if mind is unhealthy and depressed. And so if we treat depression aggressively, I have seen that it not only helps with their physical improvement, but their participation in physical therapy, participation in occupational therapy. And also research has been clear that people who are more depressed, they visit the emergency room more often, they go to hospitals more often for psychosomatic reasons. And sometimes I have seen patients just call 911 just because they feel they're uncared. Not that they are being uncared, they perceive that way because they're depressed. And so all of these aspects in life can improve with treating the depression.
I also wanted to just add also about treating depression. Our focus now is treating our patients with depression, right? Our patients in long-term care facilities and older adults. I also want to add to the caregivers that care for them. They are very stressed. Their research has shown that if they're stressed, they're caring for their loved ones, especially with those with chronic illnesses, with dementia, with any chronic diseases, that they're also prone for depression and anxiety. And so when they're depressed and anxious, they make their loved ones miserable also. They also make the staff miserable because they themselves are depressed and anxious. So I think it's also good to assess our patients, but it's also good to provide support for the caregivers and the caretakers and the professional caregivers at nursing home.
There's a very interesting point there. I've been trained in psychoanalytic psychotherapy, and we were always encouraged to monitor our own feelings when we are doing psychotherapy on patients, because patients tend to create and induce the same feelings that they have onto their therapist. So therapists have to be mindful of how I am feeling in front of this patient, because that is how they might be feeling inside themselves. So I agree with that once patient is depressed, they project their depression outside, and that can make others depressed also.
Mm-hmm. Yeah.
Agree.
And it's not acceptable. It's not acceptable in any age. It's not acceptable in younger people. It's not acceptable in older people that depression is part of aging. It's never, it's not a part of aging. So we need to treat it aggressively to have better outcomes.
Absolutely, I agree. Excuse me. And we've talked a lot about the patient's feelings and kind of their attitudes and how it really does affect the caregivers and you know, everyone involved. And I do have, because believe it or not, we are getting close to time, I do have one last question that I would like to open up to you all, because I think it is really important. And it kind of touches on depression not being a normal part of aging, like you just said, Dr. Inventor. So I'm going to ask this question, and it's meant to be a little bit thought-provoking, a little bit uncomfortable, because it's truly asking us to be honest with ourselves and really look at this from another perspective. So the question is, are our pre-existing attitudes about these crazy old ladies and these grumpy old men possibly responsible for hindering us from providing the best quality of care to this vulnerable population?
Yes.
Yes.
You know, that speaks about ageism. And that's actually one of the reasons why our treatment with older adults are not there. We need to be mindful about ageism. The thought that because of aging, you deserve to be in pain, you deserve to be, or you are prone to pain, or you are prone to be depressed, or you are depressed, and just the way of life. That's ageism, and ageism affects everything that we do. It affects how we treat our patients. It affects how the modalities of our treatment. It affects how we talk to our patients. So it affects research. We exclude the older adults in participants because of that. There are so many issues about that, but it's part of it as well. And it affects our treatment options because of ageism. So I think if there's one thing that we could try to combat on this grumpy old men or irritable ladies, that's kind of ageism. And if there's one thing that we want to educate everybody, starting from our students, starting for the people we work with, that's what it is. I think it springs from there. And then I actually, you know, I stopped myself using these senior moments because I think we label everybody as senior moments, like with senility, the cognitive decline that we call senior, we label it as such, and so it becomes an adjective to older adults, which is not supposed to be. So I think we have a way to go. I start teaching my students about ageism and how to combat it, and so it's an eye-opening. Really.
I want to tell one quick story because that was eye-opening to me. Is one of my patient's daughter, and she was a nurse, not just the outside the healthcare provider. She was a nurse, and she said, "What did you do to my mother? She has always been a mean lady throughout her life, and now she's not." And I said, "I just treated the underlying psychiatric condition, which went untreated for so many years." So the grumpy old man and grumpy irritable lady could be that they have underlying psychiatric issues that nobody looked after. So it is a good news in a way that we can make a difference. Dr. Inventor is very right that if we educate the staff, then we can recognize this, and many a times we can make a difference. Sometimes it is hard to make a difference and we have to be realistic. But many a times I have seen, and I feel so blessed that I have so many effective tools in my toolbox that I can make a difference.
You know, I want to share a funny story about a grumpy old lady and a grumpy daughter, about how I was able to go through the thing, very depressed and very resistant to medications. And then I said, you know what if I have a tool for you that would show you the best medication that you have? So I was talking about GeneSight. This is the real story. And so "Oh, you can do that?" And she said, "Yes." And so, "Oh, this is like from Star Trek." And so when I had the GeneSight panel, and then the results were there, and then there's like these green things. I said, these are things that may work for you. And so you partner with the patient then to decide which of these things that I, of course, pinpoint which one of these medications would I use for you. And that becomes it opens up because that's kind of like out of the world Star Trek level innovation that I use. And so that was an issue with, but it is an issue about the challenges that we face with the cultural challenges, with ageism, with faith, and cultural. It is an issue, and you could use all the toolbox that you have available for you.
Absolutely. Thank you for sharing that story. That was really touching, and I'm glad that hopefully that individual was helped more than they ever thought was possible, which is awesome. We are at time. I would love to keep this conversation going because there's so many, I feel like we're just getting into the good stuff, but the good news is we are going to keep the conversation going. So if you guys could join us again on Thursday evening, we're again going to be talking about those self-care tactics for providers, including monitoring one's own mental health and remembering to ask for help because we're human too. And then that importance of actually setting goals for depression with remission and not just settling for stable. So thank you again all for being here this evening. I really appreciate your time, and thank you to our panelists for sharing everything that you have. This has been wonderful, and I look forward to seeing you all back on Thursday.